those who voted for HB electrophoresis, why they voted for HB electrophoresis? Yes, Dr. Subbalakshmi, you can speak.
So this is regarding the COVID protocol that you're following in Wellness Center 5.
Yes.
Do you include chest X-ray in the initial protocol screening?
No, if the patient does not have respiratory symptoms like coughing or their saturation is low on, we don't. Otherwise, if there are other differentials, then we definitely go for, but not routinely, not all patients, selected patients.
Thank you.
Anybody wants to make any point? Those who are not talking for the presentation can reduce their noise, please. Let others speak. Anybody wants to discuss any case?
Sir, the last patient, we couldn't hear, sir. The meeting got ended.
Yeah. So I'll again go for the last case. No problem. I'll rerun the case again. So this was a young male who, during a routine office screening, his oximeter readings, pulse ox readings were 85. And this was cross-checked on 3 pulse oximeters. The middle oximeter is my own, which is a non-in, which is a very standard one. That also showed 85. And this patient I seen without any symptoms coming to my wellness center. This was sent by Dr. Chaudhary from one of our senior doctor from Camp region. So he sent this very nice case to us, and he had no cyanosis, no breathlessness. So what we asked you is, do you consider this is a strong COVID suspect or not, or something else? And looking at the presentation, I wanted to confirm his pulse oximeter readings. So we looked at arterial blood gas, and his blood gas was surprisingly PO2 was supranormal, more than 100, and his saturation was on ABG 98. And he still, even today, he has 85% saturation on his pulse oximeter without symptom. So, and all other investigation, lung scan, 2D echo, CBC, D-dimer, ECG, auscultation, everything is normal in this patient. So yes, those who have raised hand, they can go ahead and speak.
So it could be minor thalassemia, minor.
His hemoglobin is 15.5.
Yeah, okay.
And no abnormalities on MCV, MCH.
Yeah, correct.
So usually,
any skin lesion, any nail lesions he has?
No. Yeah, we checked in all, both his hands with different pulse oximeter. Even I checked each and every finger of his both hands. Reading is the same. Okay, anybody else who raised hands can speak out, because I don't see somebody. Dr. Anjali Rao is saying that oxygen carrying capacity is reduced.
Any local AV malformation, sir?
But on arterial blood gas analysis, the oxygen content is normal. And even if it is local, why in both hands on each and every finger, the pulse oximeter is showing 85.
Sir, any other variant hemoglobins?
Yeah, that is what that is why I did an HB electrophoresis. So his HB electrophoresis is also normal. No abnormal hemoglobin detected. So methemoglobin levels are normal. His HB electrophoresis is normal. No nail polish because he's a male, so no case of nail polish or anything like that. He's not using any chemical or anything. Peripheral perfusion low. No, he had a very nice warm fingers. And ABG is showing you SpO2 of 98, no lactate. If the perfusion was reduced, the lactate would go high. To at least show raised levels. But there are two to three things in this patient. One is why there is a discordance of pulse oximeter reading and oxygen content on on arterial blood gas analysis. What are the causes? So the normal causes are, if we rule out the laboratory error and instrument errors, cause is methemoglobinemia, sulfhemoglobinemia, and abnormal hemoglobins. So we checked everything, and his methemoglobin is normal, his HB electrophoresis is normal, and his all other laboratory errors ruled out, because we repeated the arterial blood gas in a different hospital just to check whether the ABG report is wrong from the first hospital. So we did that. So this is the case which is under investigation. We have reached to one conclusion, which I'll disclose once we have all the investigation. We confirm the case what it is, but the cause is focusing around hemoglobin. So what Dr. Kamesh Rao is saying is correct. Is the hemoglobin variant is what we are focusing on, but his basic electrophoresis did not show any variant. So why is
Maybe
that?
we should go in for some genetic mutations, gene mutations.
Let's see that. So that is what, but that is not being done in Pune. So somebody's dog is barking. So can we mute his mic? Can we mute his mic? So.
So which means essentially he has a hemoglobin which is carrying oxygen, but it is not able to dissociate and send it to the tissues.
Yes. So this is what variant hemoglobin presents. It will present as subnormal oxygen or poor oxygen on pulse oximeter, low oxygen saturation readings, and on arterial blood gas. His oxygen content will be it will be normal, below normal, or supranormal. All three possibilities are there in hemoglobin variants. There are different variants, like I'd like to name few of them. One is hemoglobin Cheverly, hemoglobin Tibet. There is also called as hemoglobin Surat or Indore in India. There is also a variant in Kerala. They call it as hemoglobin Kerala. There is a hemoglobin Josley. So there are very rare variants of hemoglobin which are seen, gives this type of picture, and we are after this case. But because of the logistic issues, we cannot travel to those centers who are doing these studies. There is one center in KEM, Mumbai, who does these variant studies, but we are not able to send this patient there because the KM is fully COVID now. So we have asked the patient to wait or go to Delhi AIMS for this. And I have given a summary letter to this patient. Let's see what it comes out to be. But it's an interesting case. So anybody else wants to make any point, not about this case, but overall other cases, presentation?
Sir, was the ABG done on OPD basis, sir?
Yeah, OPD basis without oxygen. This patient is without oxygen on outpatient. Yes, we do in all CKD patients, OPD basis. I do all CRF patients, their routine arterial blood gas to look for bicarb. We do venous blood gas on OPD basis. I do in for all pulmonary cases OPD basis. Somebody's So Dr. Kaushik, he was sent for low sat to WC. Yes, he was sent to, but because it was remaining low without symptoms, and he was traveling. So, and I don't know what Dr. Chaudhary thought. He also thought something not fitting into COVID or fitting into something normal. So both husband and wife, the husband is working in a office. Wife is fortunately a doctor. She's a homeopathy doctor, and she's also a little confused of what going on his, with, with her spouse. So we are on this case, but we have ruled out grossly major things. So at least the initial panic is down.
Sir, one more question.
Yes.
Sir, how about the experience with joint pains in COVID suspect or COVID positive patients? Joint pains, not myalgia, joint pains.
Joint pains. So this is one case that I have seen, but we are seeing joint pains post-COVID.
Okay.
Probably this patient might have had a week ago fever, a small fever, and that is how she presented like a chikungunya type of presentation. So even fever with arthritis, think about COVID. This was a googly for us. So I selected this fever patient because we saw around 240 fever patient screened for COVID and other diseases. So we got these interesting things in them, and I thought they are worth sharing with you all so that you may be well prepared to deal with such type of patients. And you may be saying something like this, what we are seeing. So with this, if there are no more
Sir, I
questions.
just have one question, sir.
Yes, Dr. Rao.
Sir, yeah, can you please comment on monocytes in your hemogram reports?
Yeah. So
Although they are having normal, but they look like high normal.
yes. So this is actually a slide that we have made. I've missed the monocytes, but what we have observed is if the patient is diagnosed within day or two of fever, his monocytes are higher. That means sometimes they even cross 10. 10% is the higher limit. But as the days progress, their monocyte comes down. So on which day you have done a complete blood count matters a lot. If you do early, you might see a monocyte higher. If you do little late, the monocyte are normal. So you have to know which day the patient is of symptom. This is a very important in the history. You must record this. When was the first symptom? Lot depends on this trajectory of or a temporal progression of symptoms. Lot depends on which day you are investigating, what treatment you are giving, and lot depends on outcome on that. So you must record what was the first day of symptom. So monocytes, first few days, I would say within first 48, 72 hours, they are high. But we have seen even normal monocytes. So this is little baffling. Anything else? Anybody wants to make any point? There are some chat questions.
A few observation which we have made is, so
Yes.
patient like in home isolation, so we have seen a couple of patients like turning to moderate to severe disease, say 12 to 15 days after the first onset of symptoms.
Yes.
Yeah. So
The part 4 will be on purely on home isolation. We are going to share our experience of what happens in home isolation, the guidelines, how actually those guidelines fare on the ground, what problems we have faced. So our whole team will share their experiences of home isolation. So we have kept part 4 purely for home isolation cases. So we have plenty of them. So we'll discuss these issue there. And we have with experience, we Wellness Center 5 has our own protocol We have developed our own protocol. I won't say protocol, but we have developed our own method of investigating and taking them to home isolation. And this is possible only with experience. This is not possible just going blindly with those guidelines. It's not possible. You'll land in trouble sometimes with one or two cases if you just follow those guidelines like normal saturation, no comorbidities is good for home isolation. No, it's not like that. We have come across some problems, and there have been some very surprises of surprises. Those who wouldn't get good in home isolation initially have done fantastically well despite all the comorbidities in the world. So we'll share those cases. So there is one question from Hema. Have you seen reinfection of COVID? We have seen an MTS who was asymptomatic positive on May 29. He is now symptomatic again. We have not yet come across any reinfection in my wellness center. So we don't have any experience with that. We can share this in part 4. So we thank you all doctors for attending this presentation and sharing their views. I take opportunity to tell all doctors, please take precautions. Your mask is very important. Don't disregard, don't lower your guard, and you don't means your risk does not correlate with number of cases in your cities. Absolutely not. Just take out this from your mind that if the cases in your city are decreasing, that means you are safe. It is absolutely wrong. I would say otherwise. Your risk will start rising when the city cases will go down because people will come in more numbers and your team will be relaxed. And that few cases in your wellness centers will be problematic for your staff. So be careful. So
thank you, sir. It was a very nice experience with polling, live
yeah.
polling. It was a
So we'll continue with this polling exercise. This was just a trial today, but I think it worked very well. And we also see what other doctors are thinking. And there is no correct or incorrect answer in that. So we just look for thinking. There is a question from Dr. Geeta. In the last case, do any of the siblings been tested? It's a very good question. Very nice point she has brought out. You should actually check pulse oximeter readings of blood relation in this patient. Very good point. Very good point. And we asked this question to the patient, but because his relatives are not in Pune, he does not know what kind of pulse oximeter readings his brother or mother or father has. They may be having a hemoglobin variant. So this is a very good question. Thank you, Dr. Geeta, for bringing on this point. Thank you all. Goodbye and good night. Take care.
Thank you.